Welcome back to Bright Dimension. This is Godfrey Oscar. If you haven't subscribed, please click the subscribe button. This is video number 7. Question number 61. A 19-year-old woman comes to the emergency room and reports that she fainted at work earlier in the day. She has mild vaginal bleeding. Her abdomen is diffusely tender and distended. In addition, she complains of shoulder and abdominal pain. Her temperature is 36.5 degrees Celsius, pulse rate is 120 beats per minute and blood pressure is 96/50 mm of mercury. To confirm the diagnosis suggested by the available clinical data, the best diagnostic procedure is A. Pregnancy test. B. Posterior culpotomy. C. Dilation and curettage. D. Culdocentesis. E. Laparoscopy. The answer is D. Culdocentesis. Culdocentesis is the transvaginal aspiration of peritoneal fluid from the cul-de-sac or pouch of Douglas. In this question, culdocentesis would help to confirm if the patient had ruptured ectopic pregnancy. The blood which would be aspirated during the procedure would not clot to confirm ruptured ectopic pregnancy. The DOP of the patient's blood pressure also suggests ruptured ectopic pregnant. She also has mild vaginal bleeding or spot bleeding, which usually happen in ectopic pregnant, and shoulder pain, as they also get shoulder tip pain. The procedure is done under sedation. The patient is put in lithotomy position. Vagina is cleaned with betadine. A posterior vaginal speculum is inserted. An 18-gauge spinal needle fitted with a syringe is inserted at a 0.1 cm below the cervicovaginal junction in the posterior fornix. After inserting the needle to a depth of about 2 cm, suction is applied as the needle is withdrawn. If unclotted blood is obtained, the diagnosis of intraperitoneal bleeding is established. If no blood or fluid is obtained, the needle is withdrawn slowly while intermittent suction should be maintained. If the tap is found dry, another attempt is to be made. Question number 62. A 24-year-old woman, gravida 2, para 0, abortus 1, is seen in the emergency department because of vaginal bleeding and abdominal cramps. Her LMP was 10 weeks ago. History is unrevealing except for an induced abortion 2 years ago without complications. She presently denies instrumentation for abortion. Physical examination reveals a BP of 110/70 mm of mercury, pulse 120 beats per minute, and temperature of 38.3 degrees Celsius. The abdomen is tender with slight rebound in the lower quadrants. The pelvic examination reveals blood in the vault and a foul-smelling discharge from the cervix, which is dilated to 2 cm. The uterus is 8 to 10 weeks size and tender, and no adnexal masses are palpated. What is the most likely diagnosis? A. Choriocarcinoma. B. Hydatidiform mole. C. Pelvic inflammatory disease, PID. D. Septic abortion. E. Twisted ovarian cyst. The answer is D. Septic abortion. This is due to vaginal bleeding and abdominal cramps, indicating that the uterus is trying to force out the remain products of conception. Foul-smelling discharge from the cervix indicating the infected products of conception. And dilated cervix 2 cm. Question number 63. A 35-year-old woman had a spontaneous vaginal delivery 10 days ago. She delivered a healthy baby girl and is currently breastfeeding. There were no complications throughout labor and the midwife has documented that the placenta appears complete. She now presents with irregular dark red vaginal bleeding over the past 2 days. Her blood pressure is 130/75 mmHg, pulse rate is 85 beats a minute and respiratory rate is 18 breaths a minute. She has a temperature of 37.4 degrees Celsius. What is the next most appropriate action? A. Cross-match 2 units of packed red cells. B. Cervical smear. C. Pelvic ultrasound. D. High vaginal swab. E. Reassure, no action required. The answer is D. High vaginal swab. Explanation: this is likely to be secondary postpartum hemorrhage as she presents with irregular dark red vaginal bleeding over the past 2 days. Secondary PPH is characterized by an abnormal or excessive bleeding from the birth canal between 24 hours and 12 weeks postnatally. It is most commonly caused by endometritis. Investigations should include high vaginal swab, Bloods including FBC and CRP. Consider a transvaginal ultrasound to assess for retained products if no improvement. Coamoxiclav is the first-line antibiotic for endometritis. It is safe in breastfeeding. Question number 64. A 35-year-old G2P1L1 woman at 40 weeks 6 days presents to labor and delivery triage with a 5-hour history of painful contractions. Monitoring reveals contractions every 3 minutes and cervical examination on arrival is 3 cm dilated, 50% effaced, and 22 station. Her pregnancy has been complicated by gestational diabetes and 20 kg weight gain in pregnancy, BMI 24. In her first pregnancy, she presented at 2 cm dilation and 90% effacement. Her labor progressed slowly with dilation of 1 cm every 3 hours until labor arrested at 7 cm. A healthy baby girl weighing 200 g was delivered by caesarean section after arrest at 7 cm for 4 hours. Today your patient requests a trial of labor after caesarean section. You recheck her cervix 2 hours later and find that it is 4 cm dilated, 90% effaced, and 21 station. The estimated fetal weight by Leopold's is 4,000 g. A recent ultrasound preformed at 38 weeks estimated the fetal weight at 3,900 g. You admit the patient to labor and delivery for expectant management. Which of the following factors was least likely to result in her prior failure to progress? A. Obstetric conjugate diameter of the pelvis greater than 11.5 cm. B. Inadequate strength of uterine contraction. C. Fetal size or position. D. Maternal pelvis shape. E. Fetal lie. The answer is A. Obstetric conjugate diameter of the pelvis greater than 11.5 cm. Let's not stick much to the long story in this question. This question wants you to determine which factor is the last one, or less likely to prevent normal vaginal delivery compared to the other factors. If the obstetric conjugate diameter of the pelvis is greater than 11.5 cm, that is too big. And it would least likely to cause failure of the progress of labor. Let's remind ourselves, the normal obstetric conjugate diameter is 10 cm, true conjugate diameter is 11 cm, and diagonal conjugate diameter is 12 cm. Question number 65. Ms. Maria is 33 years old, G8P5L6 woman with fundal height of 39 cm, present for initial prenatal visit in your clinic. She is currently an inmate at a local jail. She is imprisoned on charges of marijuana possession. She has had no prenatal care. She is unsure of her last period but reports that she started feeling the baby move approximately 5 months ago. She denies vaginal bleeding, leaking fluid, or contractions during the pregnancy. She reports using marijuana nearly daily throughout the pregnancy. She has not been taking any medications in pregnancy and has had no other exposures. The father of the baby is not involved. She does not have custody of her other children and has an open DHS case. She hopes to regain custody and is interested in drug rehabilitation. Ultrasound performed in your clinic shows gestational age to be approximately 40 weeks 3 days. What is the most common cause of a diagnosis of postterm pregnancy? A. Inaccurate dating. B. Fetal anomaly. C. Delayed presentation to prenatal care. D. Advanced maternal age. E. Multiparity. The answer is A. Inaccurate dating. As you can see, the ultrasound shows gestational age to be approximately 40 weeks 3 days, which is contrary to what is portrayed by the woman. The woman didn't have prenatal care. That may also be the reason. The woman is a drug user, as she has been using marijuana nearly daily throughout the pregnancy, which is likely to cause her confusion of days and months and feel as if she has been pregnant for such a long time. Question number 66. A 33-year-old woman presents to you with a positive pregnancy test and concerns about this pregnancy. She has had 3 early miscarriages in the past with no live births. Based on her last menstrual period, she is now 6 weeks gestation. She was investigated for antiphospholipid syndrome in the past and her Lupus anticoagulant antibodies were found to be positive. Her body mass index is 22 kg per meter square and she is a non-smoker. What is the most appropriate management? A. Cervical cerclage. B. Bed rest until delivery. C. Prophylactic vaginal progesterone. D. Low molecular weight heparin and aspirin. E. Reassure, no change of management. The answer is D. Low molecular weight heparin and aspirin. She has been diagnosed with antiphospholipid syndrome in the past. This puts her at risk for blood clots and she would eventually need heparin. Heparin and aspirin also reduces the risk of miscarriages in patients with diagnosed antiphospholipid syndrome. Question number 67. You confirm an intrauterine pregnancy of approximately 10 weeks gestation in a 30-year-old gravida 5, para 4 woman with an intrauterine device in place. The patient expresses a strong desire for the pregnancy to be continued. On examination, the string of the intrauterine device is noted to be protruding from the cervical os. The most appropriate course of action is A. Leave the intrauterine device in place without any other treatment. B. Leave the intrauterine device in place and continue prophylactic antibiotics throughout pregnancy. C. Remove the intrauterine device immediately. D. Terminate the pregnancy because of the high risk of infection. E. Perform a laparoscopy to rule out a heterotopic ectopic pregnancy. The answer is C. Remove the IUD immediately. You don't need to leave the intrauterine device as it can be a risk factor for infection. The best and most appropriate course of action is to remove it because the strings are seen protruding from the cervical os. Question number 68. A 38-year-old woman is seen in your clinic for the evaluation of a swelling in her right vulva. She has also noted pain in this area when walking and during coitus. On examination, a mildly tender fluctuant mass was noticed just outside the introitus in the right vulva. What the most likely diagnosis? A. Bartholin's abscess. B. Lymphogranuloma venerum. C. Chancroid. D. Vulvar carcinoma. E. Herpes infection. The answer is A. Bartholin's abscess. From the question, the swelling in her right vulva indicates a Bartholin's abscess. Being mildly tender, fluctuant, and located just outside points toward a Bartholin's abscess. Bartholin's abscess is the end result of acute bartholinitis. The duct gets blocked by fibrosis and the exudates pent up inside to produce abscess. If left uncared for, the abscess may burst through the lower vaginal wall. A sinus tract may remain with periodic discharge through it. Question number 69. On bimanual examination, you palpated bilateral adnexal masses from the abdomen examination of Mwana Hamisi. A vaginal ultrasound was done for her and it showed bilateral tubo-ovarian abscesses. What is the most appropriate next step in her management? A. Admit the patient for emergency laparoscopic drainage of the abscess. B. Admit the patient and give her 4 antibiotic. C. Treat with multiple oral antibiotics as an outpatient. D. Call interventional radiotherapy to perform CT-guided percutaneous aspiration. E. Admit the patient for exploratory laparotomy, total abdominal hysterectomy and bilateral salpingo-oophorectomy. The answer is A. Admit the patient for emergency laparoscopic drainage of the abscess. Tubo-ovarian abscesses form secondary to salpingo-oophoreitis, the inflammation of ovaries and fallopian tubes secondary to infection. Ovaries may be adherent to the tubes, intestine, omentum, and pelvic peritoneum producing tubo-ovarian mass. Such a mass is usually bilateral. Question number 70. A 32-year-old woman with polycystic ovarian syndrome has infertility of 1 year's duration. Her menses occur at irregular intervals, and basal body temperature is monophasic. An endometrial biopsy shows endometrial hyperplasia with mild atypia. The most appropriate therapy is A. Danazol. B. Megrostol acetate. C. Oral contraceptive. D. Clomiphene citrate. E. Human gonadotropins. The answer is D. Clomiphene citrate. Polycystic ovary syndrome is a complex endocrine disorder with clinical features that include hirsutism and acne, due to excess androgens, oligomenorrhea or amenorrhea, and multiple cysts in the ovary. In polycystic ovarian syndrome, there is excess androgen production by the ovaries. Typically, the ovaries are enlarged, capsule is thickened with multiple cysts along with hypertrophy of theca cells, stromal hyperthecosis. It is due to unopposed estrogen stimulation. That's why in the question, endometrial biopsy showed endometrial hyperplasia. It is also more associated with increased risk of endometrial cancer. Symptoms are such as oligomenorrhea or amenorrhea, hirsutism, alopecia, obesity, acne, and subfertility. Diagnosis involve Rotterdam consensus criteria, where 2 out of 3 criteria is 1. Polycystic ovaries, either 12 or more follicles or increased ovarian volume, 2. Oligoovulation or anovulation, and 3. Hyperandrogenism. Most patients are usually obese and have diabetes type 2, hence one of the management involve weight reduction, clomiphene citrate, and metformin. Metformin improves metabolic syndrome by reducing all the parameters, weight, BMI, hyperinsulinemia, hyperandrogenism, blood pressure, and lipid abnormalities. 500 mg thrice daily is found to correct the biochemical abnormalities. Pioglitazone and rosiglitazone are also being used in cases resistant to metformin. Subscribe, hit the bell sign, like and share our videos. Please give a comment. You were with me, Godfrey Oscar from Brilliant East. See you next time. You are warmly welcome.